Hello everyone, now let us discuss about evaluation and management part 1. Here we will be focusing on the introduction and various concepts of E&M. So what is E&M or evaluation and management services? The evaluation and management services are cognitive services in which a physician or other qualified healthcare professional diagnoses and treats illness or injury. Based on the medical management of a particular problem, appropriate CPT codes are selected. Now, let us discuss the components which govern the level of E&M. The descriptors for the level of E&M services recognize 7 components which are used in defining the levels of E&M services. This is an important point. 7 components govern the level of E&M. So what are these components? The components are history, examination, medical decision making, counseling, coordination of care, nature of presenting problem, and time. In the current session, we will be focusing on history, examination, medical decision making. Now coming to the key components of E&M. In the previous slide, we have discussed that there are 7 components which govern the level of E&M. Among those 7, there are 3 important components which are called as key components of E&M. What are they? The key components of E&M are history, examination, and medical decision making. In the current session, we will be focusing in detail about history, examination, and MDM. An exception to this rule is the case of visits which consist predominantly of counseling or coordination of care. So there are some visits which predominantly depend on counseling or coordination of care. For these services, time is the key factor or controlling factor to qualify for a particular level of E&M. In general, for majority of the services, the 3 key components are history, examination, and medical decision making. There is an exception to this rule is the case of visits which consist predominantly of counseling or coordination of care. For these services, time is the key or controlling factor to qualify for a particular level of E&M. Now coming to the history, which is the first key component of E&M. History itself is subcategorized into 4 components. History comprises of 4 components or subcategories. What are they? Chief complaint, history of presenting illness, review of system, past family and social history. Chief complaint can be shortly said CC. History of presenting illness is HPI. Review of systems is ROS. And past family and social history are PFSH. Depending upon these 4 components, history is again categorized into some types. So what are the components of history? Chief complaint, HPI, ROS, and PFSH. Now coming to the types of history. Previously we have discussed about the components of history. What are the components of history? Chief complaint, HPI, ROS, and PFSH. So based on these 4, history is categorized into 4 types. Problem focused, expanded problem focused, detailed, and comprehensive. So what are the components which contribute to problem focused history? Whenever there is chief complaint plus brief HPI, then the type of history is problem focused. Whenever there is chief complaint plus brief HPI plus problem pertinent ROS, then the type of history is expanded problem focused. When there is chief complaint plus extended HPI plus extended ROS plus pertinent PFSH, then the type of history is detailed. When there is chief complaint plus extended HPI plus complete ROS plus complete PFSH leads to comprehensive type of history. Now let us see some of the guidelines. The chief complaint, ROS and PFSH may be listed separately as separate elements of history, or they may be included in the description of HPI. In some of the records, there will be each heading like chief complaint, review of system and PFSH. But in some cases, there will be only HPI, history of presenting illness, and the physician documents CC, ROS and PFSH beneath that. In either of the cases, you can consider. The next guideline is a ROS and PFSH obtained during an earlier encounter does not need to be re-recorded if there is evidence that the physician reviewed and updated the previous information. So for an established patient, ROS and PFSH obtained during an earlier encounter does not need to be re-recorded if there is evidence that physician reviewed and updated the previous information. This may occur when physician updates his or her own record in an institutional setting or group practice where many physicians use a common record. The review and update may be documented by describing any new ROS or PFSH information or noting that there has been no change in the information. So how are we going to determine that a particular record is updated? If the physician describes any new ROS or PFSH information, then we can consider the record is updated, or simply if he documents no change in information, even in that case also you can consider that the physician has updated the record, noting the date and location of the earlier ROS and PFSH. He need to mention the date and the location of the earlier ROS and PFSH. The next guideline is ROS and or PFSH may be recorded by ancillary staff or on a form completed by the patient. To document that physician reviewed the information, there must be a notation supplementing or confirming the information recorded by others. And the next guideline is, due to any condition, if the physician is unable to obtain a history from the patient or other source, the record should describe the patient's health condition or other circumstances which preclude obtaining a history. Either physician should document the patient's health condition if he is unable to obtain history. In some cases, if the physician is unable to obtain history from the patient or other source, the record should describe the patient's condition or other circumstances that led to this result, which precluded obtaining a history, must be documented. These are some of the guidelines for history. Now coming to chief complaint. CC is a concise statement describing the symptom, problem, condition or diagnosis, physician recommended return or other factor that is the reason of encounter. Reason for encounter or reason for visit is the chief complaint, and the medical record should clearly reflect the chief complaint. Every medical record should have a chief complaint or reason for visit. Now coming to HPI. History of presenting illness. HPI is a chronological description. HPI is a chronological description of the development of patient's present illness from the first sign and symptom or from the previous encounter to the present. So it is a time-based. Chronological means time-based description of the development of patient's present condition or illness from the first sign and symptom or from the previous encounter to the present. And what are the elements of HPI? This is also an important point. HPI has 8 elements. So what are the elements of HPI? The 8 elements are location, quality, severity, duration, timing, context, modifying factors and associated signs and symptoms. History of presenting illness or HPI has 8 elements which governs the types of HPI. Now let us discuss the 8 elements of HPI with an example of pain. Let us suppose a patient presents with pain. With that example, let us discuss the each and every element. So the first element is location. What does location indicate? The location simply indicates the anatomical site of the pain. Suppose if the patient has knee pain, knee is the location. If the patient has elbow pain, elbow is the location. Next is the quality. What is quality? Next element is quality. Includes a description of the quality of the symptom. That is, for example, pain may be sharp. In some cases, there will be dull pain. In some cases, the pain is stabbing. The physician documents as dull pain. Physician documents as stabbing pain. Physician documents as sharp pain. So here sharp, dull and stabbing can be taken as quality. Next, coming to severity. What is severity? The degree of pain. For example, that can be described on a scale of 1 to 10 is the severity. The physician describes pain is 7 out of 10, 6 out of 10, 9 out of 10. It describes the severity. 9 means severe, whereas 4 or 5 is less pain. So severity is the degree of pain. The next element is duration. Duration is the time gap. How long have you had the pain? Since what time the patient is having the pain? That is the duration. The patient is having a pain since morning or since night. So that is the duration. Next is the timing. Describes when you have pain. For example, pain with exertion or pain in the evening, pain comes in the morning. So that is the timing. Next element is context. What is the patient doing when the pain begins? For example, if a patient suffers from heart attack while he is doing exercise, here the context is exercise. That is, the patient is performing his daily exercises and he got heart attack. So context is what is the patient doing or simply the patient activity when the sign or symptom develops. Context is the patient's activity when the sign or symptom develops. The next element is modifying factor. What makes the pain better or worse? For example, a patient suffering from pain, if he takes aspirin, the pain is reduced. So here aspirin is the modifying factor because it is reducing the pain. In some cases, if the patient is having a shoulder pain, lifting a heavy object further worsens the pain. Here lifting that heavy object is the modifying factor because of that the pain got worse. Modifying factor are the elements which makes a particular condition better or worse. And final element is associated signs and symptoms. Physician based on assessment may ask about the other sensations or feeling. For example, if the patient, do you experience pain while exercising? Associated signs and symptoms with a particular illness are the associated signs and symptoms. So these are the 8 elements of HPI which are very important in determining the type of HPI. What are they? Location, quality, severity, duration, timing, context, modifying factor and associated signs and symptoms. Now coming to the levels of HPI. Based on those elements, levels HPI can be brief or extended. What does brief HPI indicate? Brief HPI indicates it should contain 1 to 3 elements of HPI. From those 8 elements, if at least 1 to 3 elements are present, then that HPI is considered as brief. Next is extended HPI. If a medical record consists of 4 or more elements of HPI, or if the patient has a status of at least 3 chronic or inactive conditions, even in that case also HPI can be extended. If the patient has chronic comorbidities such as diabetes, hypertension, and thyroid, these are three chronic inactive conditions. Even though if the physician does not document 4 elements of HPI in the medical record, because the patient has three chronic or inactive conditions, then that HPI is taken as extended. Usually based on elements, it should contain 4 or more elements of the HPI in order to be called extended. So the types of HPI are brief and extended. Now coming to review systems. ROS is an inventory of body system obtained through a series of questions. Physician asks the patient to identify the signs and symptoms that the patient may be experiencing or has experienced. For the purpose of ROS, following systems are recognized. What are they? Constitutional symptoms: eye, ears, nose, mouth and throat, cardiovascular system, respiratory system, gastrointestinal, genitourinary, musculoskeletal, integumentary, neurological, psychiatric, endocrine, hematologic or lymphatic, allergic or immunologic. These are the various systems, 14 systems that have been recognized for the purpose of ROS. Now coming to the types of ROS. ROS can be problem pertinent, extended and complete. Problem pertinent should inquire about system directly related to the problem. If the patient presents with migraine, physician may inquire about the nervous system. So here the ROS is problem pertinent. Next is extended. Inquires about 2 to 9 systems from those 14 systems. If the physician inquires about 2 to 9 systems, then that ROS can be considered as extended. If the physician inquires at least 10 organ systems, then that ROS is complete. So types of ROS are problem pertinent, extended and complete. Problem pertinent, it only inquires about one system. Extended involves 2 to 9 systems. Complete involves more than 10 organ systems. Now coming to past, family and social history. PFSH. PFSH consists of review of 3 areas. As the name indicates, it reviews past history, family history and social history. What is past history? The patient's past experiences with illness, operations, injuries or treatment governs the past history. If the patient has any surgery, any treatment, any illness, that is given in the past medical history or past history. Next comes the family history. A review of medical events in the patient's family, including diseases which may be hereditary or they place the patient at risk. For example, family history of diabetes, cardiovascular system, cancer, all these things comes under family history. Next is social history, an age-appropriate review of past and current activities. Social history mainly involves the social activities of a particular person, that is his smoking status, etc. Now coming to the types of PFSH. PFSH can be pertinent PFSH and complete PFSH. At least one element from any of the 3 history areas. That is at least past history or at least family history or at least social history. If the physician documents at least one area or one element from any of 3 history areas, then that is pertinent PFSH. And if the physician documents at least 2 out of 3 elements in some cases and all 3 areas in some cases, then that is complete PFSH. Now let us discuss the types of E&M services which require 2 elements or complete 3 areas in order to be called as complete PFSH. So at least one specific element from 2 of the 3 areas must be documented for a complete PFSH for following categories of E&M services. one specific element from two of the three categories. That is at least past history and family history, or family history and social history. One element from 2 out of 3 should be documented to be called complete PFSH for the following categories of E&M services. What are they? Office and other outpatient services, established patient. For established outpatient service, 2 out of 3 areas are considered for complete PFSH. For emergency department, for domiciliary care established patient, and for home care established patient. Then what are the E&M services which require at least one specific element from all three areas? In some cases, the physician must document all three areas: past history, family history, and social history in order to call complete PFSH. What are the types of E&M services which require all three areas of history to be called complete PFSH are office and other outpatient services, new patient. For new patient of outpatient services, for hospital observation services, for hospital inpatient services, initial care, consultations, comprehensive nursing facility assessment, for domiciliary care new patient, home care new patient. In all these cases, all three areas, at least one element from each of the three areas must be documented for complete PFSH. Now coming to the second key component of E&M, that is examination. By this we complete the history. Now we are going into examination, which is the second key element of E&M. Examination types are problem focused, expanded problem focused, detailed and comprehensive. Problem focused examination, expanded problem focused examination, detailed examination and comprehensive examination. Various organ systems that are recommended for the documentation of examination are cardiovascular, ear, nose, mouth and throat, eyes, genitourinary male and female, hematologic, lymphatic, immunologic, musculoskeletal, neurologic, psychiatric, respiratory and skin. These are the organ systems. Each organ system has certain elements. Here we are not going in detail about the elements of each organ system. As of now, we will be just focusing on the types of examination. So these are the organ systems and they need specific elements. Cardiovascular system has specific elements, ENT has specific elements, eyes have specific elements, based on which the type of examination is determined. The examination guidelines are divided into two types: general multi-system evaluation and single organ system examination. General multi-system examination and single organ system examination. The general multi-system examination, it comes from 1995 guidelines of E&M. So previously they used to do general multi-system examinations. In that case, for problem focused examination, the document should include performance and documentation of 1 to 5 elements identified by a bullet in one or more organ systems or body areas. So for problem focused examination, 1 to 5 elements must be identified either in one or more organ systems or body areas. For expanded problem focused examination, should include performance and documentation of at least 6 elements. At least 6 elements identified by bullet in one or more organ systems or body areas. For detailed examination, should include at least 6 organ systems or body areas. For each system or area selected, performance and documentation of at least 2 elements identified by bullet is expected. Alternatively, a detailed examination may include performance and documentation of at least 12 elements identified by a bullet in 2 or more organ systems. For detailed explanation, let us make one separate session on examinations. As of now, just to focus, for detailed examination, at least 6 organ systems must be covered. And for each organ system and performance and documentation, at least 2 elements are expected. That is, for each organ system, 2 elements must be documented. So for 6 organ systems, 12 elements must be documented. Alternatively, a detailed examination may include performance and documentation of at least 12 elements identified by bullet in 2 or more organ systems or areas. This is little tricky. Either the physician can include 6 organ systems with 2 elements each, or he can include 2 or more organ systems or body areas and must document at least 12 elements from these systems. Next, coming to comprehensive examination. Should include at least 9 organ systems or body areas, and for each system and area selected, all elements of the examination identified by the bullet should be performed unless specific directions limit the content of the examination. And for each area or system, documentation of at least 2 elements identified by a bullet is expected. For comprehensive examination, physician must document at least 9 organ systems. For each system, all elements of the examinations identified by bullet must be performed. Or for each area or system, documentation of at least 2 elements identified by a bullet. That is, at least 18 elements identified by a bullet must be required for comprehensive examination. And for detail, minimum of 12 elements. For expanded problem focus, should consist at least 6 elements. For problem focused, 1 to 5 elements. Here you can see, for general multi-system examination, for problem focused requires 1 to 5 elements identified by bullets. Next, expanded problem focused, at least 6 elements identified by bullet. For detailed, at least 2 elements identified by bullets from 6 areas, or at least 12 elements identified by bullets in 2 or more areas or systems. And for comprehensive, perform all elements identified by bullet in at least 9 organ systems or body areas and document at least 2 elements identified by bullet from each of the 9 areas, or at least a minimum of 18 elements must be documented. Now coming to 1997 guideline, they have introduced single organ system examination. According to single organ system examination, problem focused examination should include performance and documentation of 1 to 5 elements identified by bullet, whether in a box with a shaded or unshaded border. So what is shaded border, what is unshaded border, we will discuss in detail in the session when we talk about examination. As of now, for single organ system examination, problem focused examination must include 1 to 5 elements identified by bullet, whether in a box with shaded or unshaded border. And for expanded problem focused, should include performance and documentation of at least 6 elements identified by bullet, whether in a box with shaded or unshaded border. For detailed examination, examinations other than eye and psychiatric examination other than eye and psychiatric examination should include performance and documentation of at least 12 elements identified by bullet, whether in a box or in a box with shaded or unshaded border. For ophthalmic and psychiatric examination, for eye and psychiatric examination should include the performance and documentation of at least 9 elements identified by bullet, whether in a box with a shaded or unshaded border. Next is comprehensive examination. Should include performance of elements identified by bullet, whether in shaded or unshaded box. Documentation of every element in each box with shaded border, and at least one element in the box with an unshaded border is expected for comprehensive examination. According to single organ system examination, for problem focused, 1 to 5 elements identified by bullet, whether in shaded or unshaded box. That is the only difference. Additionally, in case of detailed examination, there are two categories. For expanded problem focused, at least 6 elements are identified, must be identified by bullets. And for detailed, at least 12 elements identified by bullet for all organ systems other than eye and psychiatry. In case of eye and psychiatry, at least 9 elements identified by bullet. For comprehensive examination, perform all elements identified by bullet, document every element in each box with a shaded border and at least one element in each box with unshaded border. Now coming to medical decision making, MDM. Medical decision making refers to the complexity of establishing a diagnosis and or selecting a management option as measured by the following elements. Medical decision making refers to complexity of establishing a diagnosis and or selecting a management option that is measured by, first point is number of possible diagnosis and number of management options thus must be considered. That is the first key factor in MDM, number of possible diagnosis or the number of management options. The second key factor is amount and complexity of data. Amount and complexity of medical records, diagnostic tests and or other information that must be obtained, reviewed and analyzed. Third is risk of significant morbidity and mortality. The risk of significant complications, morbidity and mortality as well as comorbidities associated with the patient's presence problem, diagnostic procedure and possible management options. So what are the key elements of MDM? The first one is number of possible diagnoses. The second is amount and complexity of data. Third is risk of morbidity and mortality. Now coming to the types of MDM. 4 types of medical decision making are recognized: straightforward, low complexity, moderate complexity and high complexity. To qualify for a given type of decision making, 2 out of 3 elements in table 1 must be met or exceeded. So what is table 1? We will discuss further. Coming to comorbidities or underlying diseases, in and of themselves are not considered in selecting a level of E&M service unless their presence significantly increases the complexity of MDM. In general, the MDM level is determined by these 3 factors: number of possible diagnosis, amount and complexity of data. Next is the risk of morbidity and mortality. Comorbidities and underlying diseases as in themselves, they are not considered for selecting the level of E&M unless their presence significantly increases the complexity of MDM. Now coming to the types of MDM based on the 3 key elements. The 3 key elements are number of diagnosis or management options, amount and complexity of data to be reviewed, risk of complications and or morbidity or mortality. Here is the type of MDM. If the number of diagnosis is minimal and amount of data to be reviewed is minimal and the risk of morbidity and mortality is minimal, if all these 3 areas are minimal, then MDM is straightforward. If the number of diagnosis is limited and amount and complexity of data to be reviewed is limited and the risk of morbidity and mortality is low, the risk is low, then the MDM is of low complexity. If number of diagnosis and management options are multiple and the amount and complexity of data to be reviewed is moderate and the risk of complications and morbidity or mortality is moderate, amount of data to be reviewed is moderate, risk is moderate, then MDM is moderate. Then next comes the final one, number of diagnosis or management options if they are extensive, amount and complexity of data to be reviewed is extensive and the risk of complications and or morbidity or mortality is high, then MDM will be of high complexity. These are the types of MDM: straightforward, low, moderate and high, based on the three key factors: number of diagnosis and management options, amount and complexity of data to be reviewed, risk of complications and or morbidity or mortality. Now let us see some of the clinical scenarios which govern the level of MDM. So first, the level of risk is minimal. If the level of risk is minimal and if the presenting problem is self-limited or minor, for example, cold, insect bite and tinea corporis, and if the diagnostic procedures ordered are either venipuncture, chest x-rays, EKG, ECG, urine analysis, ultrasound, echocardiography and KOH prep, and if the management options are rest, gargles, elastic bandages and superficial dressings. In all these three cases, the level of risk is minimal. Because the level of risk is minimal, MDM can be straightforward. Now let us discuss second case where the level of risk is low. If the presenting problem is two or more self-limited or minor problems, or if the patient has one stable chronic illness, for example, diabetes mellitus, cataract, BPH, acute uncomplicated illness or injury, for example, cystitis, allergic rhinitis, or simple sprain. In all these cases, the level of risk is low. And for diagnostic procedures, physiological tests not under stress, for example, pulmonary functions test, non-cardiovascular imaging studies with contrast, for example, barium enema, superficial needing biopsies, clinical laboratory tests requiring arterial puncture and skin biopsies. All these things comes under low level of risk, these diagnostic procedures. And coming to management options, over-the-counter drugs, minor surgery with no identified risk factors, physical therapy, occupational therapy, IV fluid without additives. All these things, they come under low. So whenever the presenting problems are two or more and physiological tests not under stress, for example, pulmonary or functional test or skin biopsies or superficial needle biopsies are done. And when the management options are OTC drugs, either it can be or minor surgery or physical therapy or occupational therapy. In all these cases, MDM can be considered as low because the level of risk is low. Now coming to moderate level of risk. When can we consider moderate MDM? Whenever the presenting problem is one or more chronic illness with mild exacerbation, progression or side effects of treatment. For example, adverse effects, etc. Or whenever there are two or more stable chronic illnesses, or when there is undiagnosed new problem with uncertain prognosis. For example, lump in breast, or whenever there is acute illness with systemic symptoms. For example, pyelonephritis, pneumonitis, colitis, or whenever there is acute injury, for example, head injury with brief loss of consciousness. All these problems, they lead to moderate MDM. And coming to the diagnostic procedures ordered, physical tests under stress, for example, cardiac stress test, fetal contraction stress test, diagnostic endoscopies with no identified risk factors, deep needle or incisional biopsies, cardiovascular imaging studies with contrast and no identified risk factors, for example, arteriogram, cardiac catheterization. Obtain full body fluid from body cavities, for example, lumbar puncture or thoracocentesis, caldosynthesis. Whenever all these tests are performed, even in that case also the MDM is moderate. Coming to the management options, when there is a minor surgery with identified risk factors, elective major surgery, for example, open percutaneous or endoscopic with no identified risk factors, prescription drug management, therapeutic nuclear medicine, IV fluids with additives, closed treatment of fracture or dislocation without manipulation. All these management options, they lead to moderate MDM because the level of risk is moderate. Now coming to the level of risk, high level of risk. High level of risk leads to high MDM. So what are the presenting problems which lead to high MDM? MDM of high complexity, in other words. Presenting problems are one or more chronic illness with severe exacerbation, progression or side effects of treatment. Severe exacerbation. Acute or chronic illness or injuries that poses a threat to life or bodily function. For example, multiple trauma, acute myocardial infarction, pulmonary embolus, severe respiratory distress, progressive severe rheumatoid arthritis, psychiatric illness with potential threat to self or others, peritonitis, acute renal failure, etc. or any abrupt change in neurological status. For example, seizure, transient ischemic attack, weakness, sensory loss, etc. All these presenting problems, they lead to high level of risk, eventually high MDM of high complexity. Now coming to diagnostic procedures, cardiovascular imaging studies with contrast with identified risk factors, cardiac electrophysiological test, diagnostic endoscopies with identified risk factors, and discographies. All these things, they lead to high complexity MDM. Coming to management options, elective major surgery with identified risk factors, emergency major surgery, parenteral controlled substances, drug delivery by parenteral controlled substances, drug therapy requiring intensive monitoring for toxicity, and decision not to resuscitate or to de-escalate care because of poor prognosis. All these things of management options lead to MDM of high complexity. We must select the appropriate level of E&M service based on the following. The first point is, for following categories or subcategories, all of the key components, for example, history, examination and medical decision making must meet or exceed the stated requirement to qualify for a particular level of E&M. That is, for the following categories and subcategories, all the components of history, examination and MDM must meet or exceed the stated requirement to qualify for a particular level of E&M service. So what are the E&M services that require all three key components? They are initial observation care, initial hospital care, observation or inpatient hospital care, including admission and discharge services, office and other outpatient consultations, inpatient consultations, emergency department services, initial nursing facility care, other nursing facility care, domiciliary care, new patient and home services, new patient, domiciliary care, new patient and home services, new patient. Now coming to second category. For the following categories and subcategories, two of the three key components. For example, history, examination and medical making must meet or exceed the stated requirement to qualify for a particular level. Subsequent observation care, subsequent hospital care, subsequent nursing facility care, domiciliary established patient, home service established patient. When counseling or coordination of care dominates more than 50% of the encounter with the patient or the family, the time shall be considered the key or controlling factor to qualify for a particular level of E&M. This includes time spent with parties who have assumed responsibility for the care of the patient or decision making, whether or not they are family members. For example, foster parents, person acting in loco parentis, legal guardian, etc. The extent of counseling and coordination of care must be documented in the medical record. Usually the three key elements are the governing factors for the selection of E&M service. But when counseling or coordination of care dominates, that is more than 50% of the encounter time, then in such case, time is the governing factor to select proper E&M level. Now coming to the summary of guideline differences between different types of E&M services. So the new guideline is for office and other outpatient services. For office and other outpatient services, history and examination must be documented as medically appropriate. They are not used in code selection. This is the new guideline. History and examination, like previously, they are not used in the code selection, but they must be documented as medically appropriate. MDM is the key governing factor in order to select E&M service for outpatient services. May use MDM or total time on the date of the encounter. Coming to time, outpatient services may use MDM or total time on the date of the encounter. MDM elements are number and complexity of problems addressed at the encounter, amount and complexity of data to be reviewed and analyzed, risk of complications and or mortality of patient management. Coming to other E&M services, for example, hospital inpatient, consultation services, emergency department, nursing facility, domiciliary care, rest home service, or custodial care or home care. In all these services, all three components are taken for determining the level of E&M. Use key components, history, examination and MDM. May use face-to-face time at the bedside or on the patient's floor or unit when counseling or coordination of care dominates the service. Time is taken as a governing factor when counseling or coordination of care dominates the service. Time is not a descriptive component for emergency department level of E&M services. This is important point. Time is not a descriptive component for emergency department levels of E&M services. The elements of MDM are same. Number of diagnosis or management options, amount and data to be reviewed, risk of complications and or morbidity and mortality. So the simple summary of the guidelines are for outpatient services, MDM only is taken as the governing factor for selecting E&M service. History and examination must be documented as medically appropriate. For other services, all three components are the requirement. All three components are required in order to select a proper E&M service code. Thank you for watching. Please subscribe for further videos on medical coding and CPC training.